We gewoon zo beginnen, Wilma?
Ja, ik zit even te kijken. Kan ik mijn scherm al delen of moet jij dan nog iets doen voordat ik dat kan?
Nee, als het goed is kan jij doen, want ik moet wel elke keer inderdaad iets aanvinken bij de start.
Oh ja, ik zie een groen dingetje inderdaad. Heel goed. Ja. Even kijken of ik dat voor elkaar krijg. Okay. Share screen. Share.
Ik zie jou...
Ja, ik ga kijken of ik hem in presentatiemodus ook krijg. Zo zie je hem ook, hè?
Ja, helemaal goed.
Hartstikke mooi. Ik heb een klein scherm, dus ik zie echt niets meer dan alleen mijn eigen presentatie en mijn eigen gezicht of degene die spreekt. Dus ik kan inderdaad de chat niet in de gaten houden, Jan.
Nee, maar dat doe ik wel dan.
Oké.
Ja?
Ja, dat is goed.
Dus go your gang, zou ik zeggen.
Ja, 88 is genoeg.
Ja hoor, we hebben zo.
Okay. So, welcome everybody. My name is Wilma Stolk. I'm an assistant professor at the Department of Public Health here at Erasmus MC. And I'm going to take you through the burden of disease, the global burden of disease this morning. I have a background in epidemiology, health sciences. So I took a look at your course program. And, I saw some sessions around essentials of global health, with topics like the GBT, the Millennium Development Goals and the Sustainable Development Goals, environment and health, emerging infectious diseases, women's health, the big three, NTDs, tobacco, etc. There are also some lectures around Corona. For example, politics, ethics and human rights, the role of WHO, ICU care, emergency care. Then there are some masterclasses. I saw some distinguished names, but I don't really know what they are going to talk about. And there are these interesting sessions about humans of global health, and I also don't know what that is, but I'm sure that you can tell me at some point what exactly that entails. But as said, today is about the global burden of diseases. Basically, I divided the morning in 3 parts. So part 1 is an introduction to the global burden of disease studies and DALIs, and we will talk about mainly indicators. And I will also, in part 2, introduce you to some tools for visualizing patterns and trends in the GBD. I'm not taking you through all the patterns yet, because I'd like you to do that yourself. It says here there's an individual exercise, but it is actually a group exercise for you guys. And then the last part is about the global burden of communicable diseases. Okay, I was still completing this slide with learning objectives, because as you see, there are none yet for part 3. I will add them before sharing this with you. But the learning objectives for the first part is that you can explain the purpose of quantifying the burden of disease. You know, you can list key indicators of population health, and you know what a DALY is and can explain how it is calculated. And the main learning objective for part 2 is that you know where to find the global burden of disease data and how to use online visualization tools. I also like you to know some of the major trends and patterns that are observed in the burden of disease study. And I will come back to the learning objectives of the third part. So what do we actually mean when we talk about the global burden of disease? Well, the burden of a disease is the impact of a health problem as measured by mortality, morbidity, and sometimes other indicators are considered as well, such as the financial impact, the impact on income or productivity. The global burden of disease study assesses the impact of many different diseases globally. So, and why are we interested in that? Why do we want to know the burden of disease? Well, that's very important information for policy. It's input into the health decision-making process and in planning of activities. It's also important for monitoring. We want to measure progress towards our policy targets. And nowadays, accountability is also very important. So what are we getting in return for our tax money? So what are key indicators to describe the health of a population and compare population health between countries? I suggested that you type that in the chat, but now I cannot see the chat, but maybe if I stop sharing, can I somehow change screens? So just type some indicators for me.
Kan je ze meelezen?
Yes, I can read them. Thank you. It's a long and impressive list. Feel free to stop now, and I will try to go back to my presentation. Let's see, where were we? Yeah, what are key indicators to describe the health of population? That's what I asked you, and you gave me plenty of them. Indeed, there are many. The WHO on its website has a list of 100 core indicators that are relevant to look at. Of course, you cannot read this, but they distinguish 4 main groups. So in blue, it's indicators about population health status. In purple, it's about risk factors and their occurrence. In brown, there are indicators related to service coverage. And then there are indicators related to the health system itself. So let's take a closer look at these. So health status by age. For example, we have health status. We have, for example, mortality by age and sex, mortality by cause, fertility, and morbidity. And these are some of these appeared in your list. You gave more detail, for example, looking at infant mortality or child mortality. And indeed, those are very important indicators. Well, if we talk about risk factors, then you can think of nutrition, infections, environmental risk factors, non-communicable diseases, and injuries, for example. Service coverage is also very interesting. Then we are, for example, talking about proportion of people who have access to reproductive, maternal, newborn child, and adolescent health services, immunization programs, treatment programs for HIV, TB, malaria, and TTs, screening and preventive care, mental health, substance abuse, and essential health services. And when it comes the health systems, I copied the risk factors and didn't correct the information. But there we're talking about what are we paying? How many doctors do we have per capita in our population? I will fill this before circulating the file. Each of these indicators serves a very specific purpose, and some are explicitly linked to current sustainable development goals. But seeing all these health indicators, how to prioritize across diseases, how can we tell which disease deserves most effort, needs most effort? So to get better grip on that, a new indicator has been developed. Well, new, this happened in 1990. So the landmark report was published by the World Bank. It's the World Development Report 1993 about investing in health. So the World Bank commissioned WHO and other parties to do a very comprehensive assessment of the world's health problems, generating estimates for 107 diseases. So that was the first global burden of disease study, as the global burden of disease became an important new indicator with disability adjusted life years, DALYs, as the new metric to quantify the burden of disease or the burden of injuries and risk factors. The nice thing is that using DALYs, you can quantify the burden of each of those in one similar metric, making it possible to actually compare the burden of disease between diseases. The first GBD study, the GBD 1919, was done in a collaboration between the World Health Organization and researchers from Harvard University, including Chris Murray, who is still leading the global burden of disease analysis. So now, what is a disability adjusted life year? So disability adjusted life years measure the overall burden of disease expressed as the cumulative number of years lost due to ill health, disability, or early death. So it is actually the sum of years lived with disability, weighted for the severity of that disability, and the years of life lost. So it is actually the gap between what could be achieved when you live your entire life in completely good health, and what actually is achieved in reality, where you suffer from disease during part of your life and may die prematurely. So that's indicated also graphically. So the purple bits in this life course are bits where the person was diseased or disabled and therefore does not attain the full quality of life. So maybe in the last, maybe this big chunk in the end, it's a period where the person has musculoskeletal disorder, and maybe 20% of his quality of life is lost as a consequence of that. And then when the person dies prematurely, all those years until the expected life years when you would live in good health are years of life lost. So again, it is a composite health metric adding years of life lost due to premature death and quality of life lost due to living with disability, accounting for severity. And it has many useful applications. So with this metric, you can describe the health status of a population at a given time. It allows for the comparison between population groups over time and between diseases. And you can quantify the impact of interventions with this measure. So what do you need actually if you want to do this at population level? So the first piece of information that you need is the number of deaths by age and cause, mortality statistics. For example, in the Netherlands, you could probably get them from the Central Bureau of Statistics. Yeah, sometimes the necessary adjustments and corrections need to be made before you can use those data. Now, how to quantify the years of life lived with disability? Well, one way is to estimate the prevalence of different types of morbidity by age. For example, with an epidemiological survey. How many people have the disease at a given time and how severe is their disease? You have to combine that with disability weights. So say that you have a musculoskeletal disorder. You can have a mild or severe version of that. And depending on that is the disability weight. So the more severe it is, the higher your disability weights will be. Well, the Institute for Health Metrics and Evaluation, they have done large-scale surveys across multiple countries to estimate the disability weights by describing a certain health state to people. For example, you have continuously pain in your leg, and sometimes you cannot sleep at night. So how would you rate this health state? How severe is that compared to, well, maybe the best possible health state that you can achieve? So these disability weights, they were derived by the Institute of Health Metrics and Evaluation. Sometimes still new surveys are done because people feel that maybe the existing estimates are not good enough for their specific situation. So let's visualize this in another way. So we are looking now at the population consisting of 6 persons. On the horizontal axis, you see time in years. We want to know what the burden of disease is in year 2. So if the line is green, then that means the person lives in good health. If it is yellow, then the person has some form of disability for part of that year. And that means that the time spent needs to be multiplied by a disability weight to understand how many years of life are lost due to that disability. So basically you would add the yellow pieces occurring between time 2 and 3, and that gives you years of life lived with disability. The crosses are indicators of premature mortality. And depending on the age of the person at the time of death, he loses few or many years of life, right? So if you die at an old age, then your remaining life expectancy was relatively short and the years of life lost are few. If you die young, then you lose many more life years at that point. So the numbers of life years lost due to death occurring between time 2 and 3 are added to the number of years lived with disability. And that gives you the total number of DALIs. So, oops. So many diseases are associated with both years of life lost and years of life lived with disability. Here I'm looking at the group of neglected tropical diseases. You will hear more about these diseases throughout the course. And you see that especially at the bottom, many of them are actually not associated with premature mortality. So the entire burden of these diseases is caused by the disability, the often chronic disability that is caused by these diseases. For example, lymphatic filariasis can lead to a lymphedema, which means enlarged leg or arm or other body parts, which is really very disabling. Onchocerciasis can cause blindness. Same for trachoma. Intestinal nematode infections, they are very common in children and they can lead to impaired growth, stunting, and sometimes mental retardation, or that's not the right word, the mental development is delayed. Schistosomiasis is also the cause of some chronic problems, but it can also lead to premature mortality. On the top of this graph, there are some diseases for which the burden of disease is largely caused by premature mortality, including African trypanosomiasis, a sleeping sickness, dengue, and leishmaniasis. And also Chagas disease has both of them. So I'm showing this so that you understand that if you only look at mortality, you may not get the full picture of the importance of a specific disease to your population. So let's look at the disease rankings in 1919, and that's versus DALIs. So on the left-hand side, you see disease groups ranked based on mortality rates globally. So cardiovascular diseases and neoplasms are the main causes of death. But when you look at DALIs, you see that respiratory infections and TB and maternal and neonatal infections are actually the two most important disease groups. So it matters a lot how you actually quantify the impact of a disease on your population, and mortality alone doesn't give the full information. So this was the report of the first GBD study. It was a very thick book, and I think it was followed by several other books. But since this first study in 1919, several updates have been published. So initially they were done, these updates were done by WHO. So major updates took place in 2000, 2001, 2002, and 2004. Here's the report of the 2004 update. Later on, this activity was taken over by the Institute for Health Metrics and Evaluation. So Chris Murray, who was already involved in the first global burden of disease study, he actually started a new academic institute. So this Institute for Health Metrics and Evaluation, which is in Seattle and which is funded by a very big $100 million grant from the Bill and Melinda Gates Foundation. And this global burden of disease study 2010 was really a landmark study. Some of the methods have changed. They considered more diseases than before. And basically they set out to publish yearly updates. And they are nowadays published in special issues in the Lancet Medical Journal. Interesting to realize is that at each update, the GBD team is also re-estimates the burden of disease for earlier years to account for new information and methodological changes. So if you look at the initial burden of disease estimates for 1990 and the ones that they are publishing now, or that you can now find based on the latest GBD analysis, they will differ somewhat. So the best thing is always to look at the most recent global burden of disease data. So I explained that the DALYs is a composite health indicator. So if you wouldn't have any disease, then you reach your maximum longevity and you would live your life in perfect health. So in that situation, no years of life lost, no years lived with disability, that would be perfect. In real life, usually you may die prematurely, so you're talking about life lost, but you also may lose some quality of life. And as I explained before, that is captured in the DALYs. The DALYs give information about the gap between the optimum and what is realized in reality. Another metric is the health-adjusted life expectancy, the life expectancy. Those are not measures for the gap, but actually they measure the life that has been lived. And again, that can be adjusted for the quality of life. So let's look at that indicator. In this graph, we see both the health-adjusted life expectancy and the life expectancy for a number of countries. Obviously, the life expectancy is always higher than the health-adjusted life expectancy. It is too simple to say that health-adjusted life expectancy is just the difference between the optimum, the maximum life that you can live, and the DALYs, the gap, because the calculation methods are slightly different. You see in this graph that Japan has the highest life expectancy and the highest health-adjusted life expectancy, and in this graph Sierra Leone and Malawi have the lowest. Nicely sorted by income, I would say, country income. So at this point, I'd like to give you a short break. Shall we take say 7 minutes and come back. Are there any questions? Let me check the chat.
There's a question in the chat box, Wilma.
Yeah. Let me see where.
Or at least there are 3 questions about what you've been discussing.
Okay, let's see if I can find them.
4 now.
Okay, there they are. How do you measure the severity of a disability used for YLD? What do you do when someone has multiple diseases? If someone has passed away in year 2, do you look at the time the person lost only in year 2? Do you look at the total amounts of years someone lost because of early death? Yes. And why do the researchers ask random people about the severity of disease and not the patient suffering from the disease? Okay, those are all good questions. I already talked a little bit about the severity of a disability and how they did surveys. So in the original GBD exercise, they didn't do any surveys. They just asked experts, for example, doctors who know a lot about the disease, how severe they what according to them would be the disability weight. At some point they felt that that approach is actually biased. So then they moved to this new approach where actually they asked the general population about how bad they think that this certain health state is. And why not ask patients? So patients, they when they have the disease, they actually adjust. They find ways to cope with it. So their perspective is also a little bit biased, if you wish. So by asking the general public to rate all different diseases and health states, health outcomes, then you get estimates that are completely comparable and not biased by how well you can cope and other aspects. There is another difference between the early GBD exercises and the later ones, and that is also that relates to the consequences of having disease. So the descriptions that are nowadays used to describe a certain health state purely focus on health related issues. So you have difficulty doing your things, you have pain, maybe you are anxious, or maybe sometimes you think that you would rather die. That's the type of terminology that they use. So they are not incorporating any information about impact on, say, productivity. So if you are blind, they would mostly focus on maybe the social isolation that you experience, and the extent to which you can carry out your daily activities. But they are not accounting for the fact that maybe you are not able to earn your own money or to be productive in the field or whatsoever. And in the original GBD, when experts developed these disability weights, those kind of arguments were included. They were included, and later on they were left out. And sometimes this has led to very large changes, maybe somewhat unexpected changes in the size of the disability weight. I hope that has answered Nadine's question. Nishi asked, what do you do when someone has multiple diseases? Yes, that's a very good point. Because if you already have a certain disease and another disease tops it, then that doesn't mean that you can add the disability, simply add the disability weight. Maybe the sum, the disability caused by the two diseases in combination is likely to be less. than the disability, the sum of the disability weight from each separately. So they have special calculations techniques to do that. So one way that I like to think about it is that you would have to assess the disability weight of this new health state, which is a combination of the two diseases. So you cannot simply add them. To know the exact measures, I would have to get into the nitty-gritty of it. I cannot explain this by head at this point, but I hope also, Nisha, that this is sufficient for now. Naima, I think I answered your question, but let me make that more explicit. So if you die in year 2 and you lose, say, 7 years from that moment, then all those years are attributed as years of life lost to year 2. So it's not that 1 year is attributed to year 2, 1 to year 3, 1 to year 4, 1 to year 5. No, the standard methodology is that you attribute all those years to year 2, because that also gives you the best information of what could be achieved when you would be able to prevent that death. And Nadine, yeah, your last question I've also answered, I think. Is this sufficient for you? Yes, thank you. Okay, great. Well, then let's now take let's make it a 10-minute break and come back well, in 10 minutes, which is 9:47. Okay? See you. Now, can I see that?
Ja, dan gaan weer video's aan. Dus dat...
Okay.
Go ahead.
Go ahead. Great. So I'd like to start with part 2 of this morning about global burden of disease. And in this part, we're going to look into patterns and trends in the global burden of disease. And I think it's important to understand what the main contributors are, and maybe to understand some trends over time, differences between countries or country groups, world regions, countries by income, and age patterns. And I also like you to get familiar with some of the visualization tools that the GBD team has developed and which are available online. But before we get there, I'd like to start with a quiz. So I have to stop sharing now and actually give you the link to this quiz. So this is for me the first time that I'm trying it like this. Jan suggested to do that in Google Forms, so that's what I did. And I will give you the link in the chat. It's only a couple of questions, so maybe you can start filling it. Does it work? Okay. Let's see. Get email notifications. I see. Response is getting in. That's nice. Okay, according to my information, 82 of you have filled out the questionnaire. 83 now, it's okay, it's still moving slowly. I will give it a bit more time then. And the mean number of correct questions is 3 up to now. And no one had all the questions correct. I think you saw the right answers, right? When you at the end of the quiz. So if you're not done, feel free to complete the question while I continue with the presentation. I think this is interesting. Oh, wait, I need to share screen. So you see my screen now, I assume. If not, just shout out. So these questions, they can be answered using the online GPT visualization and data results tools. I give you here the links to these tools, and you will have to use those later on. The first question was about the total number of DALIs that occurs worldwide, and just to give you an idea of the order of magnitude. So the correct answer is 2.5 billion. I think that's a number that we should let sink in for a while. If you realize that the total population is 7.5 billion, then the number of life years lost due to premature mortality or disability is massive, right? It's really, really very large. And years of life lost contribute most to the total number of DALIs, namely about 2/3 is caused by years of life lost. And years of life lived with disability account for about 1/3 of the total number of DALIs. So that captures questions 1 and 2. So this is like a squared pie chart, and this shows the relative contribution of all these disorders to the global burden of disease in DALIs. So the bigger the square, the larger the contribution. And this relates to 2017. This figures for the burden of disease in 2017. And well, a very big chunk is the neonatal disorders on the left. No, in the reddish part. So the red block here is for what they call group 1 diseases. That includes maternal and neonatal, the communicable diseases, and nutrition related disorders. So we see the neonatal diseases, we see diarrheal diseases as quite a big chunk, and the lower respiratory infections are also a big chunk of the total burden. HIV at the global level isn't even that large. This has a very dark color because it has increased between 1990 and 2017. If the color is very light, it actually has decreased. So the blue chunk are the non-communicable diseases and green are the injuries. So this is a similar graph, but now the diseases are grouped at a somewhat higher level. So you don't have as many boxes and sub-boxes in each panel. On the left-hand side, we see the results for high-income countries. On the top for 1990 and on the bottom for 2017. In both years, non-communicable diseases make up for the main part of the disease burden. You see the total box size is smaller in 2017. These two, the upper and lower graphic, were created in one go, and actually the box size is an indicator of the total burden of disease, which has declined between 1919 and 2017 in high-income countries. In low-income countries, it has also declined. In 1990, it's obvious that the reddish part is responsible for most of the, well, in this case, we're looking at deaths, right? And over time, you see that non-communicable diseases start making up a larger share of the total number of deaths. But in 2017, these group 1 diseases are still very important. Okay, let's see. I see there are some chat questions. How can I Alt H? How come high-income countries experience a larger burden of neonatal bodies than low-income countries? Did I say that? No, that's not. Is low-income countries right? I think you mix up with the questions about neoplasms. Oh, okay. So it seems you've solved this between yourselves, which means that I can continue. So here I show the ranking in terms of causes of death versus years of life lost. These are not necessarily the same, because as I explained in part 1, if you die at an old age, you lose a low number of years. But if you die young, you lose many life years by premature mortality, right? So that's why the rankings for the contribution to the total number of deaths and the years of life lost are different. So why are maternal and neonatal mortality so important when you look at years of life lost? Well, obviously this includes a lot of neonatal mortality, and basically children who die very, very young or around birth, they lose their entire life. So it's many years of life lost. Well, if you die from cardiovascular disease, you die very late and lose a few life years. So globally, in terms of deaths, respiratory infections and TB are very important, with cardiovascular disease on the second place. But if you look at years of life lost, it's maternal and neonatal, which come in the first place, and respiratory infections and TB are second. Okay, so here we're looking at the DALYs and how that has changed between 1990 and 2017. See, in Africa. So in 1990, respiratory infections and TB took the first place with maternal and neonatal mortality disorders at second place, and then enteric infections, NTDs, malaria, other infections, and nutritional deficiencies. Then only at the seventh place is the first non-communicable disease, or actually it's a group of diseases. And 8 is HIV, AIDS, and STI. So many of the group 1 diseases, maternal neonatal infections, and nutrition disorders are actually in the top 10 in 1990. That's still the case in 2017, although we do see that non-communicable diseases also in Africa become more important. I think this is also a very interesting way to look at the GBD data. So this is shows the number of DALIs by age in Europe. So the dark red chunk on the left-hand side, that's neonatal mortality. It's caused by neonatal mortality, which is of course an important part of the DALIs. Then you see that actually the burden of disease, or the DALIs incurred by children, is relatively low, and it increases with age. It declines again at old age group, but that's also because of the population composition, of course. If there are fewer old people, they can contribute less to the total number of DALIs. So in children, the youngest children, we mainly see the red and dark purple. I'm not sure actually what that is, but we have the maternal and neonatal mortality, and then the purple is maybe it's other non-communicable, so that's not so informative for us. And then around the age of 65, 70, then you see that a large number of DALIs is caused by light blue groups of diseases. So we're now into the non-communicable diseases. So it's the neoplasms and the cardiovascular diseases that are very important. We also have the musculoskeletal disorders and other non-communicable diseases. And the green is again injury-related DALIs. Okay, Leonard asks, what are examples of digestive diseases? Should one think of biliary stones, stomach ulcers, or celiac diseases? To be honest, I'm not entirely sure. I'm not a medical doctor, so I don't know exactly what is captured in this term. Yeah, sorry, I cannot fully answer that specific question. You can look it up yourself if you go to the tool, the online visualization tools. So you can look at the results at different levels of detail. At some point, I showed you a square pie chart with less detail. And at some other point, I showed more detail. So you can change actually the level of detail, I think, from 1, which then you're really looking at the main groups, those 3 groups, up to 4, and then you get the individual diseases underlying it. There's always this group of other, and basically that includes the really small diseases that are too small actually to get their own category, and they are therefore grouped. So this is Europe. Now look at the situation in Africa. It's a completely different pattern, right? We see that a large chunk of DALIs is actually incurred under the age of 5. And I guess that's mostly due to premature mortality under 5 mortality. So we again have the neonatal mortality, and you see mortality from various, well, it is DALYs that we're looking at, but of course years of life lost make an important chunk of those DALYs. That's why I'm saying actually you're looking at years of life lost due to these infections. And if you remember correctly, if you die at age 4, then all years that you could have lived in normal health are attributed to that age at which you die. So a person who dies at age 4 loses, say, 80 years, and one who dies at age 80 loses 4 years. So it is very clear that the group 1 diseases are very important, and mostly because of their because they cause premature mortality at a very young age. And later on, in the older age group, you do see that group 2 diseases start to be more important. But on the scale of this figure, it seems relatively minor still. Thank you, Jan, for helping me out there. You can also visualize time trends. So what you see here is the burden of disease in DALYs from HIV/AIDS globally. Of course, you're all aware that the epidemic started in the 1980s, and well, the numbers are rising with time until a peak was reached in, say, 2006. And luckily, the burden is now declining, but still large. So instead of fatal disease, it is now a chronic disease, which changes, of course, the impact of the disease on the in terms of DALYs. So I've told you in the first part a bit about the GBD 1990, and we've now looked at numbers for the GBD 2017. So this is a very interesting, continuous exercise. The change of the GBD, the scope of the GBD work has changed. So initially they published only regional estimates, say for the large WHO regions, Africa, Eastern Mediterranean, Europe, America, so those type of regions. But soon they shifted to presenting national figures, and they are now even presenting subnational estimates for specific large countries. But for example, I've been involved in an attempt to quantify the local burden of disease, so at subnational level for 2 neglected tropical diseases in the whole of Africa. They're also looking at an expanding number of indicators. For example, indicators related to sustainable development goals, health financing, that's what they also do. They are also collating and analyzing data on COVID-19, so you can also find information on that on their website. And they do forward projections. So it is a very interesting exercise. As I indicated, it started at WHO, but it's now an academic exercise, still in very close collaboration with WHO and many partners worldwide. And I think it's still funded by the Bill and Melinda Gates Foundation. So at this point, I would like to break out in groups. I think you can sit together with your disease groups, and I think it will be interesting for you to use the GBD visualization tools to examine the health status in your country in 2017, looking at the main causes of death, main contributors to years of life lost, years of life lived with disabilities and DALYs, trends over time for maybe 3 diseases of your own interest. So I think you can do that. You could also do it alone, but maybe it's good to actually do it together so that you also can see what the others are doing and where you can find the information. And if you manage to create interesting graphs, maybe you can make a screenshot using Alt Print Screen and copy it to a PowerPoint slide deck so that you can actually store the results that you are getting. You can also, I think, one way or the other, you could actually store the link to a particular graphic, but I'm not entirely sure how that works. So you can try that yourself, but just copy pasting is already good. And you can actually include the information, the selections that you made on the left-hand side. You can include that in what you're copying. And I propose that you take, say, 30 minutes for this, and that we come back. So that would be then at 11:15, and I will then ask 2 or 3 people from different countries to share their experiences and main results. How does that sound to you?
So just to add on that,
Yeah.
Wilma, so if everything goes right, you will all be assigned to a breakout room per country. So you will be together with the students assigned to the countries of destination. There's a timer which runs the breakout room for 30 minutes, and you will get a message that time is up 1 minute before that 30 minutes, and after 30 minutes everyone will return automatically to this main room. So I hope it works. We'll give it a try.
Yeah,
Okay.
I also hope that it works. Yeah.
Seems so.
People are disappearing.
Yes, everyone is disappearing.
Except
Oh,
2.
Marloes, you were there. Max is there as well. Tell me which country. I'm not sure now by head. Max, which country were you?
Ik zit in Zambia.
Zambia. Shit, hoe krijg ik... Oh, hier zo, Max. Assign to... Ja, allemaal nieuw, man. En weg ben je als het goed is.
Maar ik zie hem nog. Nee, hij is weg.
Marloes, waar zat je ook alweer?
Zuid-Afrika.
Marloes in Zuid-Afrika. En volgens mij ben je nu ook zo weg.
Nou,
Hey.
top.
Jezus, wat een
Dat gaat goed. Ja.
Het was vooral het achterstudenten aanjagen die je niet bleken te zijn. Dat waren er maar een paar, maar nou, even.
Ja, daar ga je achteraan als ze niet opkomen dagen?
Nou, als ik er 90 plus zie en er zitten de appen er een paar van, we zitten samen in, achter de computer, dan geloof ik het allemaal wel. Maar het viel nu dus op dat er een aantal niet waren.
Ja.
Nou ja, ik ben heel vervelend hoor, dat weten ze. Dus dat wou ik er ook vooral zo inhouden met dit.
Nou ja, het is al moeilijk genoeg, zeg maar. Hè, om,
Ja, weet je, ik vind er gaat zoveel tijd en moeite van iedereen in zitten, van jou, van mij, weet ik veel allemaal niet. Ja, dan moet je er ook maar gewoon zijn hoor. Ik bedoel,
ja.
2, max 4 uur onderwijs per dag. En de rest zijn ze vrij en kunnen ze doen en laten wat ze willen. Dus,
Ja, is dat zo? Hebben ze niet allemaal zelfstudieactiviteiten?
Jawel. Ze hebben zeg maar als basis de Essentials Global Health cursus op Coursera, waar we een speciale omgeving voor hebben, nu voor dit jaar. Het is wel een zelfstudie. Maar, nou ja. Even kijken hoor, want je kan volgens mij, even kijken hoor, broadcast a message to all. Oh ja, ik kan nog een berichtje sturen naar ze. En normaliter zou je langs die ruimtes moeten kunnen. Maar hoe dat nou werkt,
Ja.
dat weet ik nou ook. Oh, join. Zie jij, ja, ik zie het staan. Als jij klikt, heb jij een button breakout room staan of niet?
Nee, ik denk... nee, die heb ik volgens mij niet. Misschien als ik more druk.
Zeg maar, je hebt share screen en daarna heb je recording en daarna breakout rooms. Zie jij dat?
Screen record. Nee, ik heb reactions. Nee, dat heb jij denk ik alleen als
Oh ja.
host.
Weet je wat ik dan doe, Wilma? Dan maak ik jou even host. Dan kan ik er
Ja.
zelf niet langs.
Kunnen we niet 2 hosten hebben?
Nee, ja, normaal zou je dus ook co-hosten moeten doen, maar om de een of andere reden lukt dat ook niet. Dus ik kan jou host maken.
Ja?
En dan krijg je als het goed is onderin naast dat share screen ergens breakout rooms te zien. Als je daar dan op klikt, dan zie je al die landen.
Dan kan je
en dan
kiezen.
kan je op join klikken en dan zit je in de groep met die studenten. Is dat een optie?
Ja, ik denk dat ik ze nog even 10 minuutjes laat prutsen en dat ik dan eens even ga rondneuzen.
Ja, oké, maar in de tussentijd maak ik jou dan even host.
Ja, dat is goed.
En dan als iedereen weer terug is in de echte sessie, dan zal ik wel weer reclaim host doen.
Ja.
Doen we het op die manier.
Ja,
Dan
ja, dat
maak
is
ik
goed.
jou nu host en dan kan je over een minuut of 10 langs al die groepjes eventjes.
Perfect. Oh ja.
En als het goed is, zie jij nu onderin naast je share screen ergens.
Ik zie een button breakout rooms.
En als je daarop klikt, dan krijg je de hele lijst met landen en dan heb je daarna join. Dus dan kan je van de ene groep naar de andere.
Ja.
Ja?
Dat is leuk zeg, ja.
Ja, grappig.
Zo,
Hè?
dit is wel
Ja.
een stuk makkelijker dan de eerste cursus die ik online deed was in Canvas. En ik heb wat
Ja,
gepost in MS
Zoom
Teams,
is
maar
echt-
dat is allemaal
Het is wel een
gedoe.
betaalde account, maar weet je, dat is, ik weet niet eens wat we betalen, €150 per jaar of zo.
Ja,
Dan heb je alle faciliteiten, het wordt allemaal opgenomen, het is allemaal terug te kijken voor studenten. Dus,
oké, ja, ik zie dat je dat ook doet inderdaad. Heel goed.
ik ga koffie halen dan.
Lijkt me
Zo
een goed
weer.
idee. Ik doe het ook. Tot zo.
Ja, mijn batterij was uitgevallen, dus ben ik uit die groep gegaan per ongeluk. Waar ik was ingedeeld.
Oh, Rishi.
Ja. Je zat bij
Nou,
Indonesië. Of
ja.
gaat dat nu niet meer lukken?
Ik weet niet hoe lang ben je erin geweest? Je hebt nog 1 minuut.
Ja, ik was er de hele tijd. Het was echt net gebeurd.
Oké, nou ik gooi je nog even terug. Kijk
Oké.
hoe dat werkt.
Kijk, en het werkt. Oh.
Het is leuk als je al die gezichtjes weer ziet komen.
Thanks for watching. We had some issues. One take. One take.
Ik denk dat iemand luidruchtig zit te typen.
Ja, geloof het ook, ja.
Nou, sorry dat ik de links zo laat deelde. Maar ik begreep, ik heb bij een aantal van jullie gecheckt en ik begreep dat jullie toch wel de website gevonden hadden en lekker bezig zijn geweest. Ja, ik ben wel benieuwd naar de ervaringen, dus ik zou een paar ja, toch van een paar groepjes willen zien wat voor plaatjes ze hebben gemaakt. En ja, hoe moeilijk of hoe makkelijk dat ging. Oh, sorry, I need to speak English. Yes, sorry for sharing the link so late. And I'd like to hear your experiences. So I'd like to ask a couple of people to actually show me some graphs and yeah, just tell me how it went. So Jan, if others want to share their screen, you probably have to make them present, or can they all do that?
They can all share
Okay.
their screen.
Okay, so that's good. So I don't even have the full list of countries in my head. But so I'm just picking some countries at random. I'd like to hear from the South Africa group. How did you do? And do you have some figures to share?
One of us has the PowerPoint presentation.
Yeah, I have the PowerPoint presentation, but I don't know how to share my screen.
So if you look at the bottom.
I got it.
Yeah.
Yeah, indeed. Do you guys see it or?
Okay. Yeah.
So we saw that HIV and AIDS causes the most deaths in South Africa. It has become less since 2007, but it is still the highest number. And then the HIV and AIDS also causes the most disability. So yeah, it's also quite logic in that country. It's very high incidences. And it also causes the most death and disability combined. I think it has become less, which you can also see right here. Whereas diabetes has become more and more. It's also to see in the trends of that what causes the most death. That the incidence of diabetes is rising, which maybe you can say that also in South Africa, the more Western diseases will come to the country. What do we have? Yeah, and these are the risk factors that drive the most death and disability combined. So it's quite logic that unsafe sex is the first one, because of the high incidence of HIV and AIDS. And yeah, so some are rising, such as dietary risks and high body mass index, which also can cause diabetes, of course. So yeah, that's what we found.
Yeah. So did you expect to see malnutrition here on the second place?
Not really, because I would expect to, if diabetes in the country, well, it's of course still a poor country, so it is quite logic that there is malnutrition, but I would expect, because the high rise of diabetes in the last couple of years, that malnutrition would become less. So,
Yeah. So I see you used a slightly different website than the one that I sent you the link to. That was probably because I sent the link so late. I saw others using that, so it is in the end it's the same data source, but I think you didn't have that many options to actually play with the data and choose what you want to show in your figures. Is that correct?
Yeah.
So these figures were just
really
given, so it's just yeah.
Yeah, these were the only things we could find on the site that we found. So.
Okay, so did you try afterwards the links that I sent?
I didn't see it actually, but I can.
Oh, I sent them in the chat.
Oh, I missed that.
Well, That's okay.
My roommate also doesn't see it in the chat, but
Oh, you don't see
maybe
it in the
I don't
chat?
know.
Oh, well, I will send them again. Right, I think now you should definitely get it as you're all.
Oh yeah, now we got it. Yeah.
Okay, so maybe it didn't work with the breakout thing. I don't know. Okay, but this is interesting. I think, well, hopefully at some point you will get to travel to South Africa, right? So now you know a little bit more about the disease burden there. Okay, I'd like to give the floor to another group. Thank you, Mickey, for sharing your screen and
No
explaining
problem.
your findings. So what other countries do we have? Did I see Oman? Is
Yep.
there? Is there someone from Oman who can share?
Okay.
Yes.
Of ik.
Doe jij maar.
Alright. Does it work?
Yes, it does.
Okay.
Yeah, so you use the same website as I gave you. Yeah.
Okay. The main causes of death in Oman are ischemic heart disease, which is on the left here, road injuries, and then we used a different type of chart, so I can't really tell which the third one is, but by far those two. And here we have the percent. I don't really understand how the rating works.
Okay, so that is the annual percentage of change between 1990 to 2017. So the color coding, so whether the color is light or dark, gives some information about what has changed and whether it declined over time or increased. So a dark color means up to a 3% increase per year on average. And a light color means that it has actually declined.
Oh, so this is not too bad, the ischemic heart disease and these
It
ones.
seems to be light, so it seems to be declining a bit.
Okay.
When you hover over that part of the graph, so in that visualization tool, then you see actually the numbers corresponding to each part.
Okay.
Yeah.
Okay. Well, this is a screenshot, so I can't do that. But
no, that's clear.
What was the second? We didn't add the questions on the PowerPoint, so I forget what.
Well, these are DALIs. What was the previous?
These are.
Oh, YLDs. YLD death. Okay.
These are deaths.
Yes.
DALIs.
DALIs. Yes, you can see it on the small letters on the top. Yeah. Okay, that changes the picture, right?
Yes. So the ischemic heart disease becomes smaller, and there's other problems that come to play more. And then for the years live with disability, it changes completely, and there's other things that come to play like headaches and drugs and depression, diabetes. So then we chose as the 3 diseases, we chose the depressive disorders, which we can see a bit of an incline, but not too much. So we chose from 1990 to 2017. This is in DALIs. Then we chose ischemic heart disease, where you can see a slight decline. And our last disease that we chose was HIV and AIDS, and we see a big incline, which we thought might be due to better contact tracing and maybe that there's less taboo, that people are more likely to consult their doctor than previously.
Okay, yeah, I'm not sure if that's the whole story for Oman. Is HIV a big problem in Oman overall? I think you can see that nicely in the squared pies. maybe in the previous year. So it's pretty small in terms of DALIs, right?
Mm-hmm.
And if you look at time trends, I think the time trends for HIV are a little bit complex, because at the start of the epidemic, it was really a fatal disease, right? People, once they had HIV, they wouldn't live very long. But now with treatment available, they live longer. So the prevalence actually goes up. And that's also what you see in the DALIs. Yeah.
Okay, yeah, that makes more sense.
Yeah.
Yeah, those were all slides.
Okay. Yes, and Jan already remarked about the huge difference between South Africa and Oman. Okay, so do you want to comment on that, Jan?
No, not so much. Just the striking that these differences are there, and I think for South Africa, to me, they really have more epidemics at the same time. So there's still a lot of HIV, and then together TB, and you also see these respiratory infections as well, and they also have this what was shown, this diabetes and cardiovascular disease problem, and I think those combined makes both worse.
Yeah,
I think that's an interaction, but that's something not for here, I guess. But I think also that if you look at many countries in sub-Saharan Africa, that looking fat is that you show that you're doing well. So the fatter you are, the more money you have, the higher your position is, the better you're doing. And that's also a problem, I guess, in many countries there, that because of culture and because of this, there's a lot of diabetes and a lot of cardiovascular disease as well.
Yeah.
Can you explain why you say Oman is a high income country because of these figures?
I think with all the money earned by oil and tourism, it's a high income country. And the students who will go there will see that there is a huge difference between real Omani people, so people from Oman, and people who are immigrants in Oman, mainly for construction and for other activities the Omani do not want to do, and many come then from Indonesia or from Bangladesh or from Pakistan. There's a huge difference in healthcare facilities and in health issues between Omani people who are well insured, have a very high standard healthcare system, versus the immigrants. There are some changes the last couple of years, but the ones who will go there will really see that there is a difference. And what's also striking is that in Oman, at least, the government really is focusing on trying to prevent this huge cardiovascular disease problem and diabetes problem. So they do a lot of campaigning on health issues. And I think if you put a slide of Oman next to the slide of the Netherlands, it's not so different.
Yeah.
Perhaps there's less cardiovascular disease in the Netherlands and more other chronic diseases like malignancies, but.
Yeah, so let's pick another country. Maybe a low-income country. So did we have Cameroon? Maybe not. Maybe Kenya?
Yeah.
Yeah, so these are the charts of Kenya. first we have like just the list of the Delhis, and a little bit like their development, like HIV is really developing. So here are the graphs. First the deaths. Well, still HIV is well one of the main causes. And yeah, in this graph you can also really see Kenya is indeed a very developing country. Like the blue part is relatively small to the infectious part. So it's like a real African country in that sense. Well, this is the graph of the Delhis. It's even more expressed in here. So still HIV, tuberculosis also a little more expressed probably. We also have graphs of the other two measurements specifically. So in years lost, indeed HIV very dominantly present. Also neonatal and lower respiratory infections. I think it has to do with what you were telling, when young children die of these causes, that a lot of years are lost indeed. So the disability indeed has to do more to do with the high income countries diseases. So I think in Kenya also there is like a part of Kenya which is developing and getting rich and getting these diseases, and therefore appearing in this chart. So then finally we have 3 diseases like you asked. HIV is on its rebound, but still in the charts still expressive present. So maternal and neonatal causes. Well, it is also going down, but as we saw in the other graphs, it's still very present. I think a lot of work can be done in that field. And the respiratory infections. And yeah, it's also going down, but still a lot can be won, I think.
Yeah. Okay, thank you. These are indeed quite typical patterns for low-income countries, I would say. Yeah.
Yes, shall I stop sharing?
Yes, I think that's okay. I'd like to see one country from the Americas. So which countries do we have there? I think we have Cuba. Are there other American countries? USA, I think one. There's also a group for the USA, right?
Yeah, there's a USA group, there's Cuba, there's Brazil, there's Suriname, Ecuador, Colombia. So
oh wow.
you can choose.
Okay. Well, let's do USA. Why not?
Okay, I shall share my screen. We only use this one, like this file. And here you can see the difference between the YLDs and the Delhis. And you see that especially, what was it? Oh yeah, diabetes is rising in a couple of years. And yeah, we have different things because here you see diabetes, so it changed with 75%.
Oh wow.
And here you see, wait, there was, wait, this, yes, this is the Delhis. Sorry, it is a little bit.
Okay, let's see.
Maybe I can.
That's okay. On the right-hand side, it says that it's the YLDs per 100,000 and not the DALIs. So I'm not sure what's on the left-hand side.
Yes. And then we also had the injuries. It was decreasing, but why the injuries will decrease with so much? Because when there are a lot of injuries in transport, you probably had some changes in the traffic rules or something, but unintentional injuries, why is it decreasing so much? So I don't know. That was quite special, I think. And yeah, the transport injuries just decreasing. And this is, AIDS is just also decreasing the last years.
Yeah. So did you look at deaths or YOL at all or not?
Yeah, we use the app. Yeah, the app. I don't know how you say it, but we have not made screens of these.
Oh, okay, that's fine. Yeah.
So
yeah, because if you look at the difference between YLD and DALI, as in your first graph, right? Then the difference is due to the YLL, so the years of life lost. So I guess that explains why when you look at YLD, the musculoskeletal disorders are ranked first. And when you look at DALIs, then the premature mortality from cardiovascular diseases and neoplasms starts playing a role, and they are actually ranking first and second.
Yes. Yeah, I understand.
Yeah. Okay, thank you for sharing. Let's take Brazil as the last country.
Yeah, so this is our PowerPoint for Brazil.
Okay.
So the top 10 causes of death for Brazil haven't changed in the last 10 years, over 2007 till 2020. It's still ischemic heart disease, stroke, and lower respiratory infections. And then next on, you see the years of life lost. They have changed since 2007. It's now interpersonal violence, which I thought is quite striking. Ischemic heart disease as well, and stroke. And then for years lost to disability, it's low back pain, headache disorders, and anxiety disorders. And then combined, you see that ischemic heart disease and diabetes and also low back pain have a big amount.
Okay, can you keep this one on screen for a while?
Yeah.
I need to understand exactly what's in here. So we have the length of the bars, that's an indicator of the increase from 2000 or decrease from 2007 2017, right?
Yeah. So I thought the communicable diseases, they decreased, right? From this.
Well, this is specifically the neonatal disorder, so that's not a communicable disease.
Yeah.
But the group, that's the only thing from the group 1 diseases, right? That we have. It's all dominated by the non-communicable diseases and the violence and injuries. It's an interesting finding. Yeah.
Yeah. And then we looked at the trends, which all decreased as well. So we looked at diarrhea from 1990 till 2016, which has decreased a lot. And then neonatal disorders as well, slightly less decrease, but also a decrease. And then congenital birth defects have decreased as well, which might...
so what's on the axis here? Do we have deaths or DALIs?
On the X is time. So this is 1990 till 2016.
Yeah.
And here's the amount of people. So this might be due to women who have better work conditions, I suppose, less chemicals or better drinking water or something like that. So this is a decrease as well.
Okay, can I ask a question about it? Because what would you expect to happen in 2018? Because it's running up till 2016.
I suppose the line would decrease further down, I'd say.
For this particular, or are you
wouldn't
talking
you
about this?
expect that there would be an increase? Someone else who could perhaps think of a reason why congenital birth defects would increase in that period in Brazil?
The
Or
Zika
from other South American
virus?
countries, but specifically Brazil in this case. Yeah, Marlou has the answer, so but perhaps he can just say it. And Josephine as well, and Valerie as well. Yeah, so there are 3 answers already. So I mean Zika virus. So I think if you come back with this figure later, that there will be a little bump because of Zika. But, not sure how big the bump then will be, but.
Okay. So that was our presentation.
Thank you. Yes, for me, I'm particularly curious what some of these figures will look like for 2020 when the COVID-19 pandemic needs to be taken into account. So what happens with the red share in this graph? So in a few years we will know. And who can't wait can already look at available data, of course, on the various websites. Well, thank you to all the presenters. Yeah, some of you used the visualization tools from the GWD. Others used some of the graphics that were already generated by the team itself. I think it's good to know that this resource is available to you so that you can actually examine things when you want to have a little bit more information about a certain topic in your country. So you can use that later on. Well, for me, yeah, every now and then for teaching, I go back into it. Sometimes also for my own work, I look at the tool. It's not always as easy to use. You have to dig a little bit into it before you understand what types of figures you can make and what they are actually telling you. Yeah. Okay, let's continue then with the last part of the presentation. Let's see if I can share my screen. Share. Yes. So this bit is really about the communicable diseases. The comparison between countries, we already saw that that group 1 diseases are more important in low-income countries than in high-income countries. And I assume that you have all heard about the demographic transition and the epidemiologic transition that are happening. So this table characterizes the stages of the transition. So in stage 1, there's very high mortality, very high fertility also. The life expectancy is short, and disease patterns are dominated by epidemics, famines, wars. Let's see. So people are asking for a 10-minute break. Do more people want that? I'm fine with having a 10-minute break. Yes, okay. Yes, please. Okay, I propose that we continue at 11:30, so you get a 13-minute break. Okay, see you back then. So we continue at 11:30, so we have 30 minutes break. We'll come back shortly. So I would like to resume. So before we went into the break, I started explaining about these important transitions, the demographic and the epidemiologic transition. I saw in the chat that there was a question about, was it the demographic?
Demographic divide.
The demographic divide, yes, that's also another concept that I was familiar with. But as the name suggests, it relates to actually the differences between groups of countries. Well, on the one hand, we have high income countries with low mortality and low fertility, and on the other hand, we still have some countries with very high mortality and fertility. And Jan has copied a link into the chat so that you can actually check that text. They give a much better explanation of the concept than I could do reading the same text. So I think you now see my presentation again, right? So I was telling about the demographic.
We don't see your presentation yet.
Oh, we don't. Okay. Share screen. Let's try again. Now you see. So the different stages in the transition. Stage 1, very high mortality, high fertility, short life expectancy, and disease patterns are dominated by epidemics, famines, and wars. For me, that feels a very long time ago that we've had that. Stage 2, high mortality, high fertility, higher life expectancy than before, but still low. And infectious diseases are important in the burden of disease, but we also start to see hypertension and cardiovascular disease. Stage 3, mortality is low, fertility can be high or low. So it varies between countries. The life expectancy is typically above 50 years. And now we see that non-communicable diseases dominate the disease pattern. So atherosclerosis, cardiovascular disease, cancer. And in stage 4, both mortality and fertility are low. The life expectancy is typically above 70 years. By then, you would expect to see a delayed onset of cardiovascular disease because of better prevention. And cancer and neurodegenerative diseases also play a role in these countries. So what then do we see when we look at trends in the burden of disease? So this is yet another way to look at the data. The figures show the trend in time over time in absolute number of DALYs caused by the 3 groups of diseases. So in red, again, the communicable maternal, neonatal, and nutritional diseases. In blue, the non-communicable ones, and in green, the injuries. So injuries remain more or less stable over time. Non-communicable diseases, the burden increases over time, and the group 1 diseases decline over time. Now look what happens if we look at the number of Dalis per 100,000 population. Now we see a decline over time in the contribution, the impact of injuries, an even stronger decline than before in the group 1 diseases, and a more or less stable contribution from the non-communicable diseases. So the difference between these two is caused by population growth. So very simply, if your population grows, there's more opportunity for Dalis if nothing changes in the health conditions and in the distribution of disease over the population. So normally you would expect an increase in Dalis in absolute terms with population growth. So the Dalis per 100,000, the decrease in group 1 diseases is even stronger than without that correction for population size. So that's a massive decline. And you also now see that the number of injuries declines slowly over time. And here is what happens if you look at age standardized data. So what do I mean? So over time, the population composition changes. Basically, you have a younger population. There are more children in the population in 1990 than in 2015. So that again changes the patterns that you see. So this is important to realize. When you look at GBD data and trends over time, you should always check, what am I looking at? Am I looking at absolute Dalis or Dalis per 100,000 or age standardized figures? But together, these three plots actually are consistent with the epidemiologic transition that is, and the demographic transition that is ongoing. Now back to the communicable diseases. In the 20th, let's look what happened in the 20th century. So mid 20th century, there was great optimism that infectious diseases would soon be history. There have been spectacular successes indeed, thanks to improved sanitation, piped water, improved healthcare, particularly antibiotics helped a lot. But also public health interventions such as vaccination, screening and preventive chemotherapy have helped a lot. And this is further helped by the availability of better diagnostics, including rapid diagnostic tests. And a big success, of course, was the eradication of smallpox in 1980. But at the same time, other eradication and elimination attempts failed. So in the 1950s, they started a big attempt to eliminate malaria globally using the new tools that were available at that time, namely chloroquine and DDT. But as a consequence of resistance, those programs have failed. Now again, there's a renewed interest in eliminating these diseases, but we are 60 years later by now. So in spite of all the advances, infectious diseases were still prominent at the start of the current century in the year 2000. They were the second leading cause of death and the leading cause of Dalis worldwide. So clearly, in the year 2000, there was an unfinished agenda for the infectious diseases. There was still no final solution for the big three diseases, HIV, AIDS, TB, malaria. Other diseases had been overlooked for a large time, and in particular, we talked then about the neglected tropical diseases. So why was that? I think I have provided you with some of the answer in the earlier part of my presentation. That's largely because many of these diseases, they stick to the tropics. So we don't see them in the West, right? But also they don't cause that much mortality. They do cause morbidity, but not that much mortality. That's another reason why they have been overlooked for quite a long time. So it's their occurrence in, well, you could say, neglected populations, the poorest populations in the poorest countries, and the fact that they don't cause a lot of mortality. Another issue that still was the case in the year 2000 is that there were still too many people dying from vaccine preventable diseases. So let's look at the figures. The number of deaths from polio and diphtheria was low, but if you look at pertussis, measles, tetanus, hepatitis B, numbers are very high. So these are vaccine preventable diseases, and many people found this finding completely unacceptable. Why? There are other reasons why infectious diseases are still very relevant in this century. Of course, we have to deal with emerging and re-emerging infections, and I think the COVID-19 pandemic is it's the clearest illustration of that we can give. Some of the emerging and re-emerging infections are very localized and geographically restricted. Think about Ebola, Nipah virus, or even multi-drug resistant malaria. And some are really global threats. So in the past, we have seen the HIV/AIDS epidemic, influenza also travels the entire scope, and COVID-19. I think that's the clearest illustration again of how quickly a disease spreads across the globe if it is transmitted easily. And then there are some evolving threats. For example, the resistance of bacteria against antibiotics. If you ask an American to make a list, then of course bioterrorism is also seen as a threat. So the USA does expect an attack in the 21st century. Of course, they don't know when, and they don't know which biological will be used. And another interesting new insight is that quite a number of chronic diseases actually do have an infectious cause to them. This I will skip, the emerging and re-emerging infectious. I think you'll have an entire lecture on them later on. So let's move on to the chronic diseases with the infectious cause. I think the most well-known nowadays may be cervical cancer, which is caused by the human papilloma virus. But there are other diseases with an infectious cause, such as peptic ulcers, other types of cancers, Burkitt lymphoma, which is caused by the Epstein-Barr virus, some types of leukemia, Lyme arthritis. So that opens up maybe the way to use vaccination in order to prevent some of these diseases, which we earlier on thought of as non-communicable diseases. So there are new routes for prevention. So I think in terms of infectious diseases, the 21st century is full of challenges for scientists. So there's many scientific advances are needed actually to meet the challenges, and that will require inputs from many different fields. So the table on the right lists some of these fields. We're talking about the genomics, we are talking about synthetic chemistry and robotics, computer mathematical modeling, molecular epidemiology, genetic epidemiology, and information technology is nowadays key to all of these fields. And a massive challenge ahead of us is developing vaccines for the big 3 diseases, and to ensure that these new tools reach all the populations in need. So here we have the Delhi ranks for the lowest as a socio-demographic group of countries, the group of countries with the lowest socio-demographic index in 1919 and 2017. So the top part of the list in 1990 was very strongly dominated by group 1 diseases and many infectious diseases also, except for the congenital defects. And still in 2017, we see that many of these infectious diseases occur in the upper part of the list. So they are pointed out with the arrow. We're talking about lower respiratory infections, diarrheal diseases, malaria, tuberculosis, HIV/AIDS, meningitis. So infectious diseases definitely remain important in low and middle income countries. This slide is a little bit misplaced due to the very short notice at which I had to prepare this lecture, but I think there is an important message here. So as an infectious disease epidemiologist, we distinguish between epidemic diseases. So an epidemic is a sudden increase in number of cases of infection affecting a large number of people within a community population. An outbreak is like a small, localized epidemic. A pandemic is a global epidemic, so spanning multiple countries or continents. And then we have endemic situations, and that's actually when an infectious disease is constant or usually present, maybe to the extent that it actually belongs to normal life to have that infection there. And that's actually the case for many of the diseases that are included in the TBD ranking. Of course, we are hoping for a world free of malaria, free of neglected tropical diseases, maybe even free of HIV/AIDS. But for now, they are just there, and they are part of life. So these are called endemic diseases. So here we see a chart showing trends in disease for 5 infectious diseases. And my question to you is, which of the following diseases does the yellow line represent? Is the yellow line for the neglected tropical diseases and malaria? Is it for HIV/AIDS? Is it for respiratory infections and tuberculosis? For enteric infections? Or is it for the group of other infections? Maybe you can type it in the chat if you know, or if you think you know. So we have one guess. Neglected tropical diseases and malaria. Some more guesses are coming in. A, C, E, B, B, C, E. So it's quite difficult to say, right? I think the thing that the one trend that we do recognize is probably the red one. I've shown that before in this presentation, and that clearly belongs to HIV/AIDS. So what are the other trends? I include the answer on the next slide. Here you see the coloring. So the respiratory infections and tuberculosis, well, we have seen that these are very important cause of deaths actually. So that's why they start the highest, and that's how you could know that these are the respiratory infections and tuberculosis. Green is the enteric infections, Red, as said, is HIV/AIDS and sexually transmitted infections. The purple line, that's the one that is most stable, actually. That's the one for the neglected tropical diseases and malaria. So up to the 2000, nothing much happened. Something happened maybe, but that's clearly compensated for by population growth, so that the number of Dalis more or less remains constant up to the year 2005, and only thereafter you see it declining. So let's take a closer look at the respiratory infections and tuberculosis. In this map, we see in which country the absolute number of Dalis is highest, and that's India. Probably just because of the very large population in that country. If we now look at the burden per 100,000 population, the figure changes, right? Because now you see that in relative terms, the burden is much larger in African countries than in India, and India isn't doing that bad at all on this graph. So here we see the Dalis lost, the Dalis per 100,000 population, I should say, lost from the different groups of infectious diseases that we discussed before by country income group, with the lowest income countries on the left-hand side and the highest income countries on the right-hand side. As we expect to see, the Dalis from these diseases are very low. Very few Dalis are caused by these diseases in high income country and high middle income countries, and they are highest in the low income countries. And here we see the years lived with disability per 100,000 population by age across all countries, again for the year 2017, from the various infectious diseases. So the lightest colors is HIV/AIDS, and that especially in the adult, working adult ages, that makes a contribution. In the younger and older groups, the contribution is relatively low. Respiratory infections, and TB, they are quite constant actually with age. Enteric infections play an important role in young children and get to be more important in older people. The NTDs, but they have actually they give in all ages they play a similar role, except for the youngest age groups, as children are mostly born uninfected. And the other infectious diseases are on the bottom. And it's the number of deaths per 100,000 population by age. So we have deaths occurring at a very young age, so among the under fives, and in the older age groups again, but few actually. Well, the majority of your life, between 5 and say 70 years, there are very few deaths from infectious diseases. So this is really an issue of the burden of disease caused by disability. So looking forward into the 21st century, there are great opportunities. We have seen that infectious diseases are still important. But we're now in a time where there's unprecedented interest in global health, in view of globalization of health problems, and but also, for example, countries in the West start to realize that improving global health in other countries is also good from an economical perspective and from the perspective of political stability in trading partner countries. So there's multiple reasons besides the humanitarian ones to actually invest in global health. And this has led to major investments by some governments and philanthropies. Are already named the Bill and Melinda Gates Foundation a couple of times. The global public health community has set quite ambitious targets that should be achieved. And they are captured in the Sustainable Development Goals. So Sustainable Development Goal 3.3 says by 2030 to end the epidemics of AIDS, tuberculosis, malaria, and neglected tropical diseases, and to combat hepatitis, waterborne diseases, and other communicable diseases. WHO has translated this broad overarching goal into into the list of disease-specific targets to control, eliminate, or even eradicate a couple of diseases. And those targets actually are guiding researchers, public and private partnerships, policymakers to actually do what is needed to achieve those targets. Even though they are ambitious, we are trying to achieve them. So this brings me to the end of my presentation. Infectious diseases are getting less important in the global burden of disease, but a lot remains to be done. And then we have the threat of infectious diseases rising or re-emerging due to climate change and globalization. Science is advancing rapidly with better tools for diagnosis, for treatment, for vaccines, and that means that there's still opportunity to fight these, improved opportunity to fight these diseases. And a key challenge is to make sure that the advances that are being made reach the people most in need. So that brings me to the end. Here are the learning objectives again, and I've now filled in the objectives for the last part of my presentation. So in part 1, we looked at the rationale for estimating the burden of disease. We looked at various indicators for population health, and you have learned what a DALI is and how it is calculated. In part 2, we looked at GBD data and some patterns in those data. And you have played around a little bit with the online visualization tools that are available. And in part 3, this last part, it was about the contribution of communicable diseases to the global burden of diseases. And we've also looked at some trends for key groups of infectious diseases. For me, that closes the presentation. So I'm happy to answer any questions if there are. Minte asks, in what way are miscarriages and premature births taken into account in the calculations on neonatal deaths? I am not sure. I guess if it happens if a miscarriage happens early in pregnancy, it's probably not counted as a premature death. And I don't know actually from which week onward it is being included.
So Wilma, I guess there are not that many questions anymore. A lot of information.
Yeah.
So thank you very much. And if there indeed are no other questions, then we end this meeting, and I will see you tomorrow afternoon, and then Wilma will be back in a couple of weeks.
Yeah, I think mid-October or so then. Yeah.
Okay.
Okay, thank you
very much.
Jan, also for helping me. And thank
was
you
nice
to all students for your active participation. Yeah.
Okay, we'll see you next time then.
Okay.
Thanks.
Bye-bye.
Bye.